Now I am going to invite Dr. Shubhankar sir. Please welcome Dr. Shubhankar sir, a clinical known for his commitment to advancing medical knowledge and improving patient outcome. And his topic is cognitive dysfunction in diabetic, movement disorder in diabetic. Please come, sir.
Thank you very much, the organizer, for inviting me. So the topic was only one: cognitive dysfunction in diabetes. These are two completely different topics. I am just using the single topic. It's not possible to cover the two very extensive topics in one session. Anyway, so first thing first, that why preventing dementia is important in persons with diabetes, because diabetes self-management itself is a challenging cognitive task, and with cognitive impairment, there is increased risk of falls, and also increased risk of hospitalization, and also increased mortality. And this worsening of the cognitive issues and the worsening of the glycemic control actually go into the vicious cycle. Now, how big is the problem? There is increased risk of dementia at least 50% among the type 1, while it is up to 60% in case of type 2. And not only that, having diabetes increases the risk of conversion from mild cognitive impairment to full-blown dementia. So, if we see the past decade experience, that both the prevalence and incidence of dementia has increased by 6.3% and 3.7% respectively among patients living with diabetes, with women particularly getting affected. Now, not only diabetes but also prediabetes hampers the cognitive performance and also causes brain aging. And now there is new data coming up regarding the cognitive status among the mother who has become diabetic during pregnancy. Having GDM also impairs the cognition among the mother, and it correlates with the glycemic status. Now, when to screen for dementia in diabetes, ADA has a very clear statement that screening for early detection of MCI or dementia should be performed for adults more than 65 years of age at the initial visit, annually, and as appropriate. By as appropriate, it means that when an individual presents with a significant decline in clinical status due to increased problems with self-care activities and medication management, those who are screened positive should be referred for further cognitive and neuropsychological assessment. But from the Indian studies, including from our center, that not only the old age but also the young and middle-aged adults are also prone to have cognitive impairment. Like in our center, we have seen that among the 20 to 60 years of age, those middle-aged diabetic patients, type 2 diabetes, having 59.2% having some sort of cognitive impairment, and odds of having cognitive impairment is 3.72 times than the control. So, cognitive impairment is prevalent among a significant portion of middle-aged educated individuals with type 2 diabetes. Cognitive evaluation should be incorporated into diabetes management from the onset with a focus on addressing the modifiable factors. And also other studies have shown that cognitive function is impaired in patients with recently diagnosed type 2 diabetes as well. So, cognitive screening for all type 2 diabetes at the time of the diagnosis, irrespective of the patient's age, is probably the new call for action. Now, the basics of the cognition, how to do it. Now, first thing is that cognition or cognitive impairment is not just memory; it is more than that. What are the domains of the cognitive human cognition? First is attention, the information processing speed. Then comes memory, executive function, language, visuoperceptual, and visuospatial. All these domains have further subdomains, and we have very good cognitive battery of tests to do this. one of the most comprehensive screening is by ACE3, Adam Bruce Cognitive Examination, ACE3. It is pretty, I must say, it is comprehensive, but takes time to do it. These are 2 pages of the questionnaire. Now, and in our center we use that. However, ADA has advocated MOCA, Montreal Cognitive Assessment Score, that is much briefer and very well sensitive and specific. Most interestingly, both ACE3 and MOCA has been validated in multiple Indian languages, including Hindi, Bengali, Tamil. Now, these are some of the performance of visuospatial and executive tests done by the type 2 diabetes patient. This is, first is wear cube, second is clock drawing test, another is intersecting pentagon, infinity diagram, and last is the TMT, that is trail making test. Now, types and patterns of cognitive impairment in diabetes, mostly Alzheimer's disease type or vascular dementia type, mostly it is mixed type. Now the question is whether actually DCI, that is the diabetic cognitive impairment, whether any specific pattern is present in diabetic or not. The thing is that there is no diabetic specific pattern of cognitive impairment. Pattern of cognitive domain involvement differs across the studies. However, problems in the memory, executive function, information processing speed, and categorical fluency are particularly affected. Now, how type 1 and type 2 diabetes differ in terms of cognitive performance? We have seen that executive function and psychomotor speed specifically worse among the older type 1 diabetes compared to type 2, while type 2 are specifically do worse in memory section. Now, if you see that how brain responds even when a single dose of bolus insulin is missed among the type 1 diabetes, there is significant decrease in the fine motor speed as well as attention and short-term memory among them, and baseline differences in the functional connectivity in the brain regions between the participants of type 2 and type 1 and normal participants were noted, and on insulin deprivation, this further alteration has happened in the functional connectivity domains. Now, what are the risk factors? There are certain modifiable and certain non-modifiable risk factors. I am coming to the non-modifiable risk factors. The female sex, most of the studies have documented that being female is probably a risk factor of developing cognitive impairment, but not all studies. Age of onset, especially among type 1 diabetes, if it is less than 5 years of age at the time of diagnosis of diabetes. In the ERIC studies, it has shown that for type 2 diabetes, individuals with middle age onset of diabetes have significantly higher lifetime risk of dementia than those with older onset. And duration of diabetes has also been claimed to have a significant association in some but not all studies. Genetic polymorphism, ApoE4 and BDNF has been thought to have important role in modulation of the cognitive function in diabetes. Now, what are the modifiable risk factors? HbA1c inconsistent result in the contrary to the popular belief, actually having a very nonlinear weak relationship. In Carolina Cognition Substudy, it is a bell-shaped relationship. Rather, glycemic variability is much more closely related to the cognitive performance. And hypoglycemia is not associated with cognitive decline if it is level 1 or level 2. However, strong relationship with severe hyperglycemia in type 1 diabetes. On CGM, greater target below range relates with lesser information processing speed. Now, other thing that particularly the hypertension and also the comorbid psychiatric ailment have important bearings on the cognitive performance among diabetes. Another thing is obesity. Now, it is much more complex than previously thought. Some studies have also shown that higher BMI in type 2 diabetes may be cross-sectionally associated with the better cognitive performance. However, this needs much more detailed evaluation with body composition analysis. Now, cognitive dysfunction with how it relates to the other angiopathy complication. It has been established that retinopathy, nephropathy, painful neuropathy, autonomic neuropathy, particularly with osteotic hypotension, myocardial infarction, stroke, and diabetic foot ulcer are all associated with decline in the cognitive performance. Now, can it predict it? There are researchers have developed some scoring system. Importantly, the age of the patient, their education, and also there are other certain points like history of acute metabolic events, microvascular disease, diabetic foot, cerebrovascular disease, cardiovascular disease, and depression. In our experience, we have seen that we have evaluated 125 Bengali-speaking patients with a extensive exclusion criteria to minimize the other risk factors, and having formal education at least up to class 4 between the 22 and 60 years of age. We had used 4 kind of questionnaire. One is CDR, MMSE, we all know, and MOCA and SCHE. We have seen that type 2 diabetes subjects reported a more subjective sensation of forgetfulness. MMSE is actually insufficient screening tool, while on MOCA and SCHE there was significant difference in total score between from the control group. And based on ACE, 59% patients had some sort of cognitive impairment, and odds of having cognitive impairment in type 2 diabetes was 3.72. Now, particularly the memory, fluency, and visuospatial ability was particularly jeopardized. Female, less education, lower status, BMI less than 23, having peripheral neuropathy, having hypothyroidism, even though those are euthyroid on eltoxin or levothyroxine supplementation, and having anxiety and depression were particularly associated with the cognitive impairment. Now, insight from neuroimaging. How a brain in patients with diabetes look like? More cortical atrophy, brain is getting aged by 3 to 5 years more, having lobar atrophy, predominantly frontotemporal lobes are specifically altered, and also there is asymmetric hippocampal atrophy. Right hippocampus is more involved than the left one. Reduced gray matter volume, reduced white matter hyperintensity, white matter volume, and also there is increased white matter hyperintensity volumes and grading. On tactography, there is microstructural white matter integrity and connectivity loss, increased Virchow-Robin space or perivascular space, also increased lacunar infarct and microbleeds. These are some of the pictures in our own series having these patients relatively were devoid of any major cerebrovascular diseases. Still, their brain look like this, having this much of burden of vascular burden and also the atrophy. In our center, we have found that these patients had more global cortical atrophy, having more periventricular white matter demyelination and prominent Virchow-Robin spaces. However, these alterations had no association with the cognitive performance, and the results are also inconsistent across studies, showing poor correlation between structural imaging and cognitive performance. Now coming to the functional imaging. So fMRI, resting test MRI, fractional anisotropy, amyloid PET, SPECT, these are the upcoming modalities to evaluate the brain of a diabetic patient. Now coming to the new thing, the glymphatic system. This glymphatic system is a kind of waste urine system in the brain, and this is particularly affected among the patients with diabetes. Decreased ALPS index is a very okay, I'm just finishing it. So, just conclusion. It is 15 minutes done. When I don't think so. Anyway. So, last few slides, just care of the patients with diabetes and dementia, avoid hyperglycemia, less stringent HbA1c goal, choose anti-diabetic with emerging benefits on brain health, encourage physical exercise, which has been proven benefit to have improved cognitive performance, encourage CGM use only if there is sufficient caregiver support, and psychosocial support is also important. So cognitive dysfunction is DM is common and can start as early as 4th decade. Cognitive screening should be encouraged in diabetic clinic. Mechanisms of dementia in diabetes involve mixed vascular and neurodegenerative pathologies. Both AD and non-AD pathways interact. Risk factor management remains the cornerstone in prevention of progression of dementia in diabetes. Choice of anti-diabetes therapy should be guided by its impact on brain health. Thank you. Thank you. I just keep those slides, ma'am. Among the non-insulin therapies, metformin has at least proven safety or benefit, and the evidence is much stronger if the patient's age is less than 80. Number 2 is regarding sulfonylurea. Overall, gliptins and metformins both scored better than sulfonylurea in terms of preserving the brain health of these patients, and it has also been shown that sulfonylurea, specifically glyburide, may have some detrimental effect in cognitive performance. Number 3 is gliptins appears either neutral or beneficial. Number 4 is pioglitazone seems safer but cautious use among the older due to impact on bone health. Number 4 is SGLT2. Most of the studies are coming up with a positive impact on brain health. And lastly, GLP-1. GLP-1, ma'am, across the studies, large database has shown that it improves the cognitive performance. However, sadly, GLP-1 has failed to preserve the brain health among the patients who are having early Alzheimer's disease in EVOKE and EVOKE Plus trials. It reduces the biomarkers of neuroinflammation like tau and A beta 40 by 42, but clinical deterioration it could not prevent. It actually failed. There is much talk about GLP-1 and brain health, but the only randomized clinical trials, 2 trials, EVOKE and EVOKE Plus, they actually failed to show clinical improvement of cognitive performance by GLP-1 among the early AD patients. Yeah, ma'am. Ma'am, control and uncontrolled you define by HbA1c, right? So that is a very, our understanding should be more it is uncontrolled, more the bad. This is the normal null hypothesis. But the thing is that HbA1c does not play that consistent role. Rather, having other micro and macrovascular angiopathies, they correlate more well. And also among the glycemic markers, the glycemic variability probably play a much bigger role than HbA1c alone. HbA1c is pretty inconsistent result. In our study as well, we did not find a significant relationship with HbA1c. Yeah.